Okay, so lots of you asked for a really focused session on direct inguinal hernias for MSRA revision.
Yep, a common topic.
Exactly. So we've got the revision notes right here, and the plan is basically to pull out all the key high-yield info you absolutely need. Make it clear, make it stick.
Sounds good. Let's dive straight in.
Right. Definition first. What exactly is a direct inguinal hernia?
Okay, so it's a specific type of inguinal hernia. It means some abdominal content is poking through a weakness
Well, weakness where?
in the posterior wall of the inguinal canal.
Mm-hmm.
And crucially, it's medial to the inferior epigastric vessels.
Medial. Okay, that's the key landmark then. Directly through the back wall. Medial. Got it.
That's a good way to remember it.
So what causes that weakness in the first place, the etiology?
Well, it's usually down to the transversalis fascia and that posterior wall becoming weaker.
Why does it get weaker?
Two main things, really. Just getting older, wear and tear, and also increased intra-abdominal pressure over time.
Ah, okay. Like chronic coughing or straining.
Exactly that. Things that repeatedly put pressure on the abdominal wall.
Right. So who tends to get these most often? Risk factors.
Yeah, there are definite risk factors. There's a useful mnemonic, MATPS.
MATPS. Okay, break that down for us.
Sure. M is for male sex, much more common in men. A for advanced age. C is for chronic cough or straining.
Like we just said.
Precisely. The second A is for previous abdominal surgery. P is for that increased intra-abdominal pressure we mentioned. And S is for certain syndromes like connective tissue disorders. Ehlers-Danlos is a classic example.
MACTPS, male age, cough, abdominal surgery, pressure syndrome. Nice one.
Helps it stick.
Definitely. So pathologically what's happening? The wall's weak, then what?
So that weakness essentially allows abdominal contents, could be intestine, could be omentum, to push directly through the posterior wall.
And it doesn't follow the path of an indirect hernia.
No, exactly. The important distinction is the sac doesn't pass through the deep inguinal ring. It's a more direct route out.
Makes sense, hence the name. Now, differentials. Someone comes in with a groin bulge. How do we differentiate this from other possibilities?
Good question. You got to think about indirect inguinal hernias. Obviously, they do go through the deep ring. Femoral hernias are another big one, lower down usually.
Mm-hmm.
And you always need to consider if it might be incarcerated or strangulated. Those are emergencies. And sometimes it could just be a lipoma or another soft tissue mass.
But the key for direct is that medial position relative to the vessels.
That's your main clinical clue,
Yeah.
Medial to the inferior epigastrics.
Okay. What about epidemiology here in the UK? How common is it?
The incidence is around 17 per 100,000 males per year. And like we said, with risk factors, it's definitely more common in older men. Peak age is sort of 50s, 60s.
Gotcha. Older guys mainly. So clinically, what does the patient actually present with?
Typically, it's groin discomfort or maybe outright pain. Often gets worse with activity, coughing, lifting, anything that raises that intra-abdominal pressure.
And the bulge.
Yeah, you'll often see or feel a swelling or bulge in the groin area. It might be reducible, meaning you can gently push it back in, or it might be irreducible. And anatomically,
Medial to the inferior epigastric vessels.
you got it. So, quick scenario, 60-year-old man, new groin pain, worse when he coughs. Where's the swelling most likely located if it's a direct hernia?
Medial to the vessels. Okay, I think I've got that bit. How do we confirm the diagnosis? Investigations.
Primarily, it's a clinical diagnosis. A good examination is usually enough.
Just by feeling it.
Often, yes. But ultrasonography is very helpful too, especially if it's small or the diagnosis isn't clear. It lets us see the hernia and the vessels.
And CT or MRI?
Occasionally needed, maybe if there's diagnostic uncertainty or suspicion of complications. But ultrasound is the usual go-to after examination.
Right. And management. Once diagnosed, what's the UK approach?
For symptomatic hernias, the standard treatment is elective surgical repair.
What kind of repair?
It could be a herniorrhaphy, which is basically stitching the defect closed, or, more commonly now, a hernioplasty, using surgical mesh to reinforce the weak area.
Open or laparoscopic?
Both options are available. Depends on the patient and surgeon preference. But if it's incarcerated or strangulated,
Urgent surgery.
absolutely, that's a surgical emergency.
And what's the outcome usually like? Prognosis?
Generally pretty good. Surgery is usually successful. Recurrence rates are relatively low, especially with mesh repair. So yeah, favorable prognosis with the right management.
Good to know. But things can go wrong. Complications.
Yes, definitely potential issues. The main ones to remember are incarceration, where the contents get trapped, strangulation, where the blood supply to those trapped contents gets cut off. That's very serious.
Life-threatening.
Can be, yes. Needs immediate surgery. And the third one is bowel obstruction, if bowel gets trapped in the hernia.
So a simple way to remember those.
Think trapped, cut off, blocked,
Mm.
incarceration, strangulation, obstruction.
Trapped, cut off, blocked. Got it. Okay, so quick summary for MSRA revision. Direct hernia means medial bulge, weak posterior wall. Older men typically, worse with pressure, usually needs surgery.
That nails it. And maybe a final thought for you. Consider how lifestyle factors, like maybe occupation involving heavy lifting, could directly impact that intra-abdominal pressure and potentially increase someone's risk over time.
Interesting point. Definitely something to think about. Right, for more detailed notes and questions on this and everything else MSRA, do check out pastmsra.com.
And don't forget freemsra.com for loads of free resources too.
Excellent. Thanks for that really clear breakdown.